Good morning, everyone. Good morning, folks. Getting a couple of minutes later start here than expected. Make sure we give you enough time for coffee and settling in and so forth. So just wanted to get things rolling here. So good morning, everyone. My name is Omar Khan, and I wanted to first of all wish everyone a happy Mother's Day. So let's give everyone a nice round. Whoever is a mother, has a mother, had a mother. Thank you, everyone. I hope you had a wonderful time yesterday. I was telling someone that so my mom has a flower shop, and so yesterday was spent in the traditional Mother's Day way, which is me trying to figure out what to get her except flowers, because as you can tell, that would get old. The other half of the day was spent doing deliveries for her, because you can never be too old or too important to do flower deliveries for your mom. So made $12 in tips, so that was good. So thank you, everyone, for coming. This is our fourth annual Community Research Exchange, and it's wonderful to see many new friends, old friends here again. Just to get things started here, how many folks have been to any Excel event before, including this conference? So really, most folks. Wow, that's fantastic, really. So all old friends then. So that's very nice. How many folks are from the University of Delaware? All right, okay, blue and gold. How many from Christiana Care? Quite a few. Wow, green representation. How many of you traveled all the way from South Carolina for this? I know we have maybe one or two. Thank you. Carolyn and others are stalwarts. Thank you. And how many from Nemours? Great. How many are you from our partner organizations in the community? Community-based organizations, not one of the previous four. Very good. All right. Well, thank you so much. So this is terrific. We have a nice program for you, and my task is relatively simple. I'm going to try to keep us on track. My wife said my main job is making sure that the tie I'm wearing today isn't the one that's in your conference photograph, my conference photograph. So I think I've succeeded in that, but I'm not sure. You got to tell me. Not known for my sartorial variety. We are honored to have several of you who have been chairs in the past of our sessions. We're very pleased that you are back, so thank you for that. I'm going to go over a bit of an overview here of the program and tell you what we're in for, so you don't have to leaf through your book. So we are currently at the top of the program. Next up, we're going to have Dr. Binder McLeod speak, and then our keynote speakers, followed by two platform presentation sessions, which will all be here. So the room numbers are listed. They're all 101A and B, which is where we are right now. After the break, we'll be back here for our 12 noon talk and our lunchtime panel. And after that, we'll be going into the workshops. And all of you should have a color on your badge which indicates what workshop you're in. If you don't have one, or if you wish to make any changes, please see Jennifer Passarella, the program manager, who's in the back waving to you. There she is. And she will help you out. The room numbers of your workshops are listed here. They're also in your program. And find Jen or myself if you have questions. We'll help you out. So I want to start off, rather than ending with thank yous, I want to start off with thank yous. This event wouldn't have been possible without our terrific team from across Excel and our partner organizations. So first of all, I want you to help me thank Jennifer Passarella, who's our conference manager, who helped make this possible. So thank you, Jen. Our terrific volunteers and staff, Holly Zerhusen, Lee McCormick, Nicole Harrington, Leslie Stallnaker, Erin Regal, Suzanne Perfield, Terry Petticone, Yamina Haywan, and Mary McElwain from across the Excel institutions have done a terrific job. Our Community Advisory Committee, several of you are here. Thank you for your help and expertise. Our Christiana Care External Affairs folks, and the gentleman who will occasionally point his camera at you, Scott Ellis. Our Excel communications team, Dan Eckridge, Dr. Mike Peterson, of course, all of you. And Stuart's not going to like it if I don't mention the Excel funding. So let's give everyone another round of applause, please, for helping put this together. So thank you. I want to start off by introducing Dr. Stuart Binder McLeod, who is here somewhere, I think. Oh, here you are, Stuart, yes. So Dr. Binder McLeod is the program director and the principal investigator for the Excel program. He is an incredibly accomplished researcher. His full bio is listed in your program, and several of you, if not all of you, know him already. Most importantly, he's been a mentor and a friend personally, as well as throughout the Excel program. He has 20 continuous years of NIH funding, which is a terrific accomplishment, and I think he's going to come and tell us why he'd like to make that 25. So please join me in welcoming Dr. Binder McLeod.
Thanks, Omar. As a leader of the Delaware CTR Excel program, it's my pleasure on behalf of the entire leadership team to welcome everyone here to this 4th annual research exchange, community research exchange. Omar stole my thunder a little bit in terms of polling to see who has been to a previous Excel event, but I noticed there are some of you who in the audience who have not been to an Excel event, so I'm just going to tell you a little bit about the Excel program and the special relationship that we have with our community engagement and outreach component. But first, I also want to thank all the individuals who helped to organize this conference, and to thank the community engagement and outreach efforts, those involved in those efforts throughout the year, including our Community Advisory Committee. Thanks to all of you so much. You're doing a great job. I'd also like to welcome someone new to the Excel program. Dr. Lee Pachter is out here in the audience. Dr. Pachter has I don't think he's been working in Delaware for more than 1 week. Yes, so he's very, very new. He's going to be working with Dr. Bittner Fagan. He will be leading the Nemours efforts with respect to the community engagement and outreach effort, and I just want to certainly welcome Lee. Thank you for being here. The Excel program is one of 9 clinical and translational research programs within the entire nation that's funded by the NIH. Each of the current clinical and translational research programs are required to include 3 specific key component activities. That's NIH jargon for things you have to do. There has to be a pilot program, there has to be an epidemiology and biostatistics support service, and there has to be a career mentoring and education program. Each of these components are specifically designed to promote clinical and translational research within the state where the CTRs reside. In addition, we were allowed to include 1 or more optional key component activities that will help to promote clinical and translational research. Please know that the Delaware CTR Excel program is one of the few CTRs that includes a specific key component activity related to community engagement and outreach, and we have by far the largest community engagement and outreach effort of any of the 9 CTRs. And we're proud of that. Although it's hard to believe, the program is about to enter, the beginning of next month, its 5th and final year of original funding. Time's gone by quickly, I can tell you. For those of you who are familiar with grant funding, this means we are currently busy preparing our application for a competitive renewal, which we anticipate that we will submit either late September or early October. This will enable us to get an additional, hopefully, if we're successful, an additional 5 years of funding. With respect to our community engagement and outreach efforts, please know we are not only continuing to include community engagement and outreach as an optional KCA, but we're working very, very hard to integrate community engagement into every single component of this grant. And I want to thank Dr. Bittner Fagan for her efforts on that front. We see our efforts, our CEO efforts and activities, such as this community research exchange, as one of the many ways that we've been successful over the past 4 years to promote and expand the clinical and research capacity within the state of Delaware, as well as South Carolina. And I personally look forward to continuing to work with those involved in community engagement and outreach to lead the nation in innovative programs over the next 6 years. Hopefully, if we're successful. I hope everyone has a productive and rewarding day, and I once again want to thank Dr. Khan and all those involved in organizing this conference and putting together such a great program. I'm sure you will enjoy it. I just want to wish everyone best wishes for a great day. Thanks so much.
Okay, I left out several important housekeeping things in my introduction. So the most important of which is, for me at least, the coffee is right outside. The second most important is that the restrooms are over there, and that there are plenty of folks to help answer your questions should you want. Also, Wi-Fi. If you need Wi-Fi access, there are little cards at the registration desk which you can pick up and get into the network there. Okay, it is my pleasure to introduce to you our keynote speakers for today. They also have extensive bios and backgrounds, and I encourage you to read all about them in the program. I'm going to give you just a really brief overview of their work. Dr. Bowen Chung is joining us from UCLA. He's an associate professor in the departments of psychiatry and biobehavioral sciences at the Harbor UCLA Medical Center, and he's an associate professor as well at the David Geffen School of Medicine, UCLA. I understand you get a good record collection at the David Geffen School. Is that right? Yeah. Okay. All right. Good. Dr. Loretta Jones joins us also from California. She is founder and CEO of Healthy African American Families. She is a civil rights advocate, a health policy advocate, and she also serves on the Precision Medicine IRB for the National Institutes of Health. I learned about them at the annual Clinical and Translational Science meeting a few years ago. I've been familiar with the work in community mental health for several years. I've always been impressed by the partnership that they've demonstrated in that work. They actually won the Team Science Award at the ACTS conference a couple of years ago, and I thought that this story is wonderful. We should really share that with you all. I thought I had this really clever idea, and I was talking to Bowen and Loretta in a conference call a few months ago, and I said, listen, instead of having a traditional keynote, could you guys maybe come and do this together, show the partnership between community and research? And they said, yeah, well, we always do that. So it wasn't a particularly brilliant idea on my part. That's kind of what they always do. You also have seen keys on your desk. I don't know what that's about, but I think you'll agree that they put the key in Keynote. So I want you to help me in welcoming Dr. Bowen Chung and Dr. Loretta Jones. We got you mic'd up, Loretta?
Yes, it's mic'd up.
Okay.
I hope they do.
All right. How you doing? Excellent. Thank you. You gonna be at the podium?
Yeah.
Okay. Wonderful. Here's your.
Thank you.
Back here.
So, believe it or not, Loretta and I got engaged about 14 years ago. We're almost on our 14th anniversary.
I think so.
Okay. Isn't that how's it been?
Oh, I need to tell you, it's been an up and down. Up and down. I love him, but it's up and down.
We're in research. We've been engaged for about 14 years. I've never actually popped the question, mostly because she's never said yes. I'm not sure if she'd say yes. And okay. Believe it or not, this is actually, it's true community-engaged research. If everybody's read all the stuff from the NIH, Barbara Israel, Nina Wallerstein, and all that, it really is a marriage. And I'll tell you.
It is?
It really is. It's about sharing, right?
It is sharing, it's respect. It's a lot of the things that you'd automatically think of in just relationships. And our relationship has been, like I said, up and down. When I first met Bowen, the love of my life, he was putting his foot in his mouth, and he was chomping down to his kneecap in a community meeting. And it was horrid.
We talk about money.
Oh, yes,
we talk about money,
do.
and we share money.
And we share it kind of equally.
That's right.
We don't feel like community is the afterthought of somebody.
And if I ever write a paper or grant without asking her opinion or permission, even though I know she would agree, like any wife, she gets kind of upset. And I get an earful, and she may not talk to me for a little bit. This is actually not a joke. I mean, it's a real thing. And my girlfriend, who reminds me, said, we've known each other for 20 years. My girlfriend, she says, Loretta's trained you very well, but not well enough. But I think this really goes to the importance of, sorry, this is going in and out, goes to the importance of, you know, science is adhering to principles in a very real way. And, you know, I think a relationship like a marriage with the community partners is really important. Because in the end, that's what drives translational research, because the T4 part's really supposed to be about how science can align with people's values, whether people will use it, whether people trust it, whether people feel it's relevant to them. How many doctors have read a study and said, my patients aren't like that? My patients are sicker, right? That quality of care study. So this is really important to really translate, I think, you know, what we call NIH-funded science to what we call population-level health impact, because if it's not meaningful or doesn't reflect my values, or I'm not engaged or invested in it, or I see myself as relevant to me, what's the point?
I think the other thing that's most important is when you're talking about community engagement, you really have to sit down and think about what the word engaged really means. And if you really believe you're in an engaged relationship, you always want your partner to feel better than you. You always want your partner to be more recognized than you. And so, like when I go out and I talk about Ken Wells and Bowen Chung, I talk about how our relationship started and how we have worked through it, and how even with the up and downs, that we've been able to ensure that community's voice is always at the table.
Yeah, and the other important thing is, you know, and this is for real, I met her after my residency, and we've been working together, and Ken Wells, who was originally invited to do this, who's a psychiatrist, does a lot of depression research. We started together, actually, when Ken, he was an accomplished researcher, was already in the Institute of Medicine or National Academy of Sciences, and Loretta became his mentor in the community, in a real way. And one of the first things we learned is that, and you read about this in the books, and I read about this in all the CPR books, is like, it's all about process, right? Because that's so important, and also because it takes such a long time to do this kind of work, and a commitment, whether the money's there or not. And I'll tell you, that timeline, over 15 years, almost 15 years, the money wasn't always there, right? That the partnership still continues.
And the work got done.
That's right. So this is just a sense, I just want to point this out, that this is work that we've done over 14 years, almost continuously funded. There have been some small gaps.
And can I say something?
Yeah, sure.
The most important thing is that we didn't bring community along as a rubber stamper. Community's voice was accurate, community's voice was thoughtful, and community's voice was valued. And that word value has a part of it that's so important when we talk about value. How do we value our partners? How do we value our friends? How do we value our families? And if we put all of those in the same collective pot, then you know that the value has to be consistent, and it has to be always, and it has to be thoughtful every time you open your mouth and say, well, I'm going to invite the Community Advisory Board. Well, who is the Community Advisory Board? And how do they reflect the diversity of what you're doing? That is so, so important. And how do you bring them on board? And how do you keep them on board? How do you continue to recognize them? And one of the things I wanted to say that was so fun was when we received our
Clinical Translation Science Award.
yes, the big award. One of the things that we did was we had 220-something partners. And when we went back to community, we took, and our academic partners, we took back certificates for each one of them, the same kind of certificate that we received in Washington. We made sure that every community partner had, and every clinical partner had that same certificate, that they could put it on their resume, that this is what they received for the work that they did, not just the work that Bowen and Ken and myself did, but that this was the work that was done by community and our academic partners, whether it was someone who was just doing data management or someone who was just doing what, cost analysis,
Cost effectiveness.
cost effectiveness, economic partnerships. Everybody had an opportunity to get their certificate. So today, all of those folks actually have a certificate like I have.
Yes. And, you know, one of the things, so I'm a child psychiatrist by training who does mostly work in adult chronic disease now. I've become an amateur internist or family practitioner wannabe. And one of the first things I learned was when I came out of my psychiatry residency, because I still see patients, and actually it's important when you looked at the first slide, I am a full-time county employee of Los Angeles County, believe it or not. In order to make this relationship, all the science work, I work at RAND, which is a think tank that does policy research. I have grants at UCLA on the main campus. I have at certain times been a staff member at Healthy African American Families, which is a health advocacy organization. And the county actually has valued this work so much that they have allowed me, and if anyone knows about state or local or VA kind of positions, that they've allowed me basically free time to do this. Because they feel it's of value because they understand the value of how to take the things that are done at UCLA or at RAND or at other universities and how to translate it into probably the largest public mental health system in the world. So one of the first things is, as a psychiatrist, I came to the community, I said, you know what, depression's a brain disorder, right? It's like hypertension, it's like diabetes, and you treat it with medications, you treat it with cognitive behavioral therapy, maybe ECT sometimes, right? And that's what it is. But the community said, you're wrong. Depression is the condition of my people. For 4 years, we actually did a very traditional CVPR project called Witness for Wellness, and the first thing they said was, you guys are using a deficit model of health, that's not going to work for me. Right? We really want, it's about wellness, right? And it's about achieving like the best you can be in life. And you know what, lo and behold, in the 1950s, the World Health Organization said the same thing, and I was wrong. Well, maybe not completely wrong, but kind of wrong. I had a very limited view of things. Really what we're trying to achieve, and this is what the community partners have said all along when they talk about social determinants and prisons and all that before it became in vogue, was it's not just the absence of a mental disorder, it's not just a deficit model, but it's a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, and can work productively. And I used to read this and think this was just something you read, but it's the community, this is what the community, if you listen to them, that's what they say.
And they also wanted you to know that when they used the word depression, they did not want to be considered crazy.
That's right.
And so a lot of the community would say, I'm not going to talk about depression because I'm not going to be identified that way because I don't want my job to think I'm crazy. I don't want my family to take and identify me as crazy, as the sick person in the family. And so we're not going to use that. We'll call it sadness. We'll call it stressed out. We'll call it not being able to cope this week, not having the ability today to be well. I'm just physically exhausted and mentally tired, but I'm not depressed.
And, you know, one of the other things is that, and this is important, it's not about, you know, one of the reasons why we get all this money to do this research is because, you know, I think Congress and the federal government, in a very real way, and state governments, really do want to do something around racial and ethnic disparities in health. They want people to get healthier because of our science, right? Sometimes it's drugs, sometimes it's new medical devices, sometimes it's processes like quality of care. And really, I think one of the things that I'm still learning is about equity. And this, once again, is from the World Health Organization. It's not just me or her or some sort of, you know, sort of fringe group. And what they say is that it's the absence of avoidable or remedial differences groups among people. It's not just equality. It's about sort of what access to resources do people need to achieve optimal health. And we really tried to do that within our work. And we spent a lot of time, let's say about 4 years, trying to figure that out with funding and support from Robert Wood Johnson Foundation, the NIMH, and the NIH. through some developmental center work, and to their credit, and later on through the CTSIs. We would have not been able to do any of our work without the CTSIs. Because, I think in the end, when I think the NIH directors go to Congress, they say, someone will say, hey, but you know what, we look at all the statistics, did the health improve because of your science? We made, we made like how many billions and billions of dollars investment, and did anything improve in your state for cancer outcomes, cardiac outcomes? And did the poor, under-resourced communities do better? It would be a really nice story to say that someone did better from the science, wouldn't it?
One of the things that we want people to understand is we don't want you to call them underserved communities. We'd like for you to call them under-resourced communities, because that's, in fairness, what they are, and it gives a more respectful tone to community. When you say underserved, that means I'm serving you, and when I get finished with you and I don't want to serve you anymore, I'm going to walk away. And that's historically what communities have seen. But when you say under-resourced, that means that the resources were never implanted in that community in the first place. So there's always been an inequity in the work.
And the sort of person who's always in the background, who I've channeled the community, but also channel Ken. I've worked with him way too long than a junior investigator is supposed to. That's what team science is about, right? I had to argue to my promotion committee that I was not actually just being used as a research assistant, but I was making a sort of an equitable contribution to the science and team science, and that's a big risk for a junior faculty member to take, to work with the same group for 14 years. That's not what's supposed to happen, but that's what we did. But really, it builds on some more traditional work. So Dr. Wells is a psychiatrist and a leading health policy, health services researcher who actually worked at the RAND Corporation, and during the medical outcome study, worked on sort of the impact of depression on insurance plans during the RAND health insurance experiment. And what he found was, depression actually, in that study, what they found was that, I think the measures like the SF-12 that came out found that depression is probably the leading, at the time it still is, the leading cause of disability in the United States. And I think just recently it was announced that it's the leading cause of disability in the world among adults. So roughly what depression is equal to a heart attack, stroke, or cancer. It's very common, so it's nice as a tracer condition, as they say, to study how things in the world work, right? How policy work or doesn't work. And unlike a stroke or a heart attack, the thing about depressions or cancer is that it tends to affect people during their prime working years, especially women. When we like to say people work, live, and love, right? It affects how you work. It affects whether you're able to take advantage of opportunities in your environment, get along with your kids, your family, everything. And one of the things about depression, it's very similar in prevalence in the population among adults. Women get it twice as much as men during their reproductive years. So there's some suggestion that's slightly lower in minorities, but it's really common. And he did one of the first primary care behavioral health integration studies called Partners in Care in the 90s. There's also Impact, or the AIMS Center, for people who do stuff in primary care. And what they found was that before they did quality improvement, this collaborative care intervention, that minorities, African Americans, Latinos, they randomized clinics, not people. They randomized 55 clinics across the United States. They found that African Americans and Latinos were 5 times less likely to get picked up for depression and 5 times less likely to get appropriate care for depression. And what do you think the outcomes were? Horrible, right? Relative to whites. After they did this, randomizing different clinics across the country to what they call quality improvement, basically giving them resources to screen, track, and educate people for depression. They found that, and worked with teams to do this, they found that African Americans and Latinos improved at 5 times the rate of whites, both in quality and outcomes of care. That's remarkable. It's the first study actually in the entire literature, medical literature, that was able to reverse racial and ethnic disparities in both processes and outcomes of care. The first study. And what happened over 5 or 10 years is that unemployment went down and net worths went up. They erased about the equivalent of the national unemployment rate, about 4 to 5%. But Ken said, so the translational part is, how do you take this and actually move it to places, right, where people are going to benefit the most from it? So he said, let's do this in South LA. Let's study this. Let's see how do we get out there. Let's do another study, right? And if anybody's met Ken, and I'll show a video of him later, as Loretta likes to say, he's the whitest man in the world. He is very white. And you know what? We can't just go, I can't. There he is. We can't just go into the community and do research. I can't just go up and say, hey, I got this research project, you want to participate? What's going to happen?
Why do we need a research project? I mean, come on now. If you're not going to come and do something with us to make us better, why are you coming into the community? That was the first question the community asked, is, so what? You got a research project? So what? Is it going to change anything in my community? Is it going to make things better in my community? And if it's not, I don't need to talk to you. I don't have time to talk to you. It also needs to be transparent. We need to be able to see what's going on both in front of the data and behind the data. So let's not talk about something in front of us and then secretly go write a paper that talks about us in a bad way. That's really important. And there was a need to talk about power sharing, you know, between the community and the university. Why are you coming to the community? And are we going to share in this? Are we going to be able to tell you no about anything? Or are we just going to be this yes group that you want? There's a lot of times they have advisory groups, and I have to tell you what they want from an advisory group when they put them together is they want someone who says, okay, okay, do it. And that's all they want. They don't want someone who says, excuse me, but why are you doing that? What's the effect of that? How is it going to affect the community? Is it going to make the community better? Are we going to do anything with this data that's going to change anything? How are we going to make policy from this? So there was that way. And then the other thing that was really important was to look at community and look at how many people know what the PhD of the sidewalk is. No one in the room knows what a PhD of the sidewalk is. No one? I can't see one.
People haven't had their coffee yet.
Okay. So anyhow, I always ask questions, want you to answer me if you know. But a PhD of the sidewalk is a person from community who knows as much about community's norms as you would know about your field of endeavor. That they've been out in the community for 20 years, therefore they have 20 years experience with what the community's norms are. They know what goes on every corner. They know about Miss Jane down the street, that she smokes tobacco. That they know about Miss Mary across the street that houses all the kids in the neighborhood, to Mr. Jones, who goes around and fixes everything for community. They know about all of these things, as well as they know about where the robberies are and where the liquor stores are that are selling cigarettes at single cigarettes, one at a time, which is illegal. So it's that PhD matched with a PhD in the university put together becomes a phenomenal,
It's very powerful.
powerful group, because then you really get to hear the two. How is this going to work? And is this survey going to work in this community? And are you going to be able to get healthcare workers to come out in this community and do this kind of work? And what do they need to learn before they come out? Do they need to be trained on community safety? Because that's going to be an important piece. So,
Yeah, no, I think that, you know, and how many people have tried to do drug trials or any sort of intervention trials, and what's the participation rates? How hard is it to recruit? Yeah, I'm going to keep that one silent, because everybody knows how hard it is. This is for real. We have UCLA, RAND lawyers review MOUs. That's about data ownership, IP ownership, disagreements, financial publications. We have a clause in all of our MOUs about minority reports. So if we have a paper, we haven't had to invoke this quite yet, but it's come close, where we have a paper where the community doesn't agree with our partners don't agree with our writing, we have to write a letter to the editor saying that we will submit this paper only under the, and if it's accepted, only under the sort of condition that the community partners can write a minority report that agrees or disagrees with parts of the publication. And the Rand lawyers and the UCL lawyers, with their wisdom, and Drew, actually, Charles Drew University, have signed off on it. And so if any IP comes out of it, and actually, I'm surprised, it may come to bear, the IP part, soon. And it's a marriage. So one of the things we had, and to go back, is how do you start doing research in community? Well, Loretta and Ken went to lunch because Loretta, the best way to get Loretta to sort of hear anybody out is take her out for a nice meal, just like any woman.
Can't you tell?
And they discussed a project about depression. And so, depression, she said, this goes back to other conversations. Depression's not a biological illness. It's the condition of my people. It's about the Middle Passage. It's about institutional racism. It's about men in prison, black men in prison. It's about the broken roads. It's about the police coming in and arresting everybody. It's about child welfare. It's about the dead bodies that kids have to sort of cross when they're going through Compton, right? And the worst part about it is you can't use the word depression. That's stigmatizing. So how do you do a depression project and not even use the word depression? That's hard, right? I was like, I just got out of my psychiatry residency. I'm a doctor. I'm board certified. I know what I'm doing. They were like, no, you don't, Bowen. Right? And so we did a project called Witness for Wellness, and this was our first about 3 or 4 year project. And basically, it was about sort of working with the community to sort of figure out how to even talk about depression. Because you can't even agree on a common term. Where are you going to go? So we had an initial conference in 2003 with about 500 or 600 people, right?
Yes, we had to throw people out the door and deal with the fire marshals. And guess what? When we decided to do this project, I went out and I asked a few people. You hear the word few? No more than I think 10 or 15 people. Should we have a conversation and a conference on depression? And before I could get the flyer, before I could get my IRB approval, I had over 200 people who had enrolled to be a part of our conference itself. And I hadn't done anything, hadn't published it in any place other than just to talk to my few friends. So that made it imperative that we did this. And we did it in a way that showed folks how to navigate. And one of the things, if you look across the bottom of this, it says share, look and listen, and record. And that's all that research is about. Those are the common words that say what research is about, and so everybody can understand them. And then what did this group of people want to do? They wanted to first talk about awareness. They wanted to take and find out if there were quality care programs within the community, and then they wanted to change things by doing policy. And then we asked community, so how do you do this? And this nice poster was designed by community.
And just to give you a sense, so we're on a bus on a road to wellness. We're on a bus. One of the things about Loretta's model, which is a variation on community-based story research, it's called community partner story research, is that it has a structure. It's now manualized, and we have it published, where we get an executive committee together and actually have subcommittees. They're equally staffed by community partners. Actually, it's 2 to 1 for chairs, 2 community partners, or 3 community partners to 1 academic chair. And we're on a road to wellness. And the important thing here is that everybody can get off the bus when they need to, and they can get back on if they want to. And it's fueled by principles of trust, respect, participation, knowledge, and experience. And as Loretta said, basically trying to translate what science is to what the community would understand. It's basically sharing, looking and listening, and recording impact and process, right? And everybody's responsible for this. In fact, the person who's homeless and who never talks, but just decides to come for the meeting, are the people who aren't at the meeting, because Loretta always says, who's not here that we need to have here, are the most important people to listen to, because in the end, their knowledge is the thing that we're trying to solve. We're trying to solve and crack that nut of the things that we don't know or we don't hear, or trying to track, like the homeless smelly person at the table, to be honest, right? Their experience is the experience we're trying to fix in every way, shape, or form. And we had 3 groups that come out of this. One was called Supporting Wellness, which was about promoting policy. Second was Building Wellness, community outreach and quality service. And third was Talking Wellness, which was the group I led. And just as a note, so the person I co-led this group with for about 4 or 5 years is a woman named Kavita Patel, who's an internist. And actually, after this project, she became the deputy director of HELP, the Health, Education, Labor, and Pensions Committee, when Senator Kennedy was there. And she's the one, she worked for Obama in the community engagement in the White House. And the reason why she got that job, and she worked at RAND right after that, was because he said she was the only one he's ever met who had both a policy background and really understood how to work on the streets. So out of Building Wellness, the Supporting Wellness, which was the policy group, we ended up with somebody who helped shape healthcare reform in the United States. And it was really because of that experience, and she'll tell you that.
And I think that one of the things that he did not tell you is that all of our groups of participants who help plan and community work on different committees, all of them took the CITI. Everybody knows what the CITI is? It's the IRB test.
Yes.
So that you can participate and collect the data and be able to touch the data and look at it and talk about it in a very clear way. So that was an important piece, was that we opened up my office, which is a community advocacy office, and allowed people to come in from community on their days off or in the evening and actually do the CITI on our computers if they did not have access to them at their own. And we did it with UCLA, with Rand's IRB, or with Drew's IRB, so that they at least had one of those IRBs where they went through completely and got the CITI certification.
And we'll get to the science. Hopefully, we always fall behind, right. So be patient. We have numbers somewhere. But one of the things I did want to point out is that one of the things we had to do was really take what the community wanted very seriously. And they said, in my group, we have to do outreach and education in the language that people understand. So we had poetry events. We went to the Pan-African Film and Arts Festival, and we did sponsored documentaries about the Middle Passage. We did surveys, believe it or not, that had RAND stamped on it, and people said, am I going to fill that out? Don't they do work with the CIA or something? But this is important in that we had to sort of learn how the community partners thought about depression. And so this is an example of some of the poetry events we had in the community that was more the formative work that led to the R1 and the Center grant later that did our Community Partners in Care study. It's called Depression.
And this one is called Depression. Hissing silence curls in my brain, squeezes my eyes open. Nights are not friendly. They are too long. Days are no better. The big sky has shrunk around my head, pushed the walls in. I am too tired to resist. The musty visitor slips under my door. My incense burns, no match. He moves relentlessly through the loose weave of my dream catcher and catches me before I sleep.
So this is important, and actually, where's the science? We still haven't gotten to the science. And I'm actually not going to show you the publication that wrote. But so we did a lot of surveys. Actually, there's two important things I'm going to say. One of the common themes in our work is that since this formative work, we did surveys with about 1,000 people about their knowledge, attitudes, and beliefs about depression based on this. And actually, we had a 95% participation rate of people we approached, of 1,000 people. We did this Pan-African Film Festival, which takes place on 2 weekends in February during Black History Month. Has about 50,000 people in South Los Angeles. They also have it in Atlanta, where we sponsored all these events. And we had 95% participation. It was like, 98% minority. And we actually developed a measure of community engagement, a pilot measure that we published in the American Journal of Public Health. And that was my first publication. It took about 3 years to get it accepted into the American Journal of Public Health. But this is kind of the example. So we're going to jump very quickly into the R01 and the Center grant.
Just tell a little bit about why all of these logos are
definitely. I'm getting to that. So Community Partners in Care is both a research partnership and study. That's the one we won the award for. And it was funded by a lot of different organizations. Our Wood Johnson Foundation, NIMH, it was a Center grant and an R01. We had California Endowment Funding, which is a local foundation, California Community Foundation. PCORI has generously continued to fund some of the follow-up interviews. And what the experiment was basically, how do we get depression care out there? Depression collaborative care. So a dissemination implementation study. And what it was is we randomized organizations and agencies and programs to different ways of doing depression care. So we had 50 agencies with 95 programs in both Hollywood and South Los Angeles. And these are all the logos. We had housing, we had behavioral health services, the largest contract provider of behavioral health, substance use and alcohol services in Los Angeles County. We had LA County. We had Queens Care Health and Faith Partnership with the Community Benefit Plan. It's a public health nursing program in Hollywood. We had Charles Drew, Kaiser was aboard, NAMI, Urban Los Angeles. We had Hollywood Senior Centers. We had barbershops, beauty salons. We had parks and recreation. We had mom and pop substance use places. We had everything except libraries because the county and the city don't get along in Los Angeles. And what we did was we randomized, well, actually, let me see, I'll go forward first. We don't have that slide. So what we did was the whole study itself was done using Loretta's model, where we had an executive council, right? We had an MOU, and what we studied was 2 different ways of disseminating and implementing this depression collaborative care approach, partners in care. We did a typical technical assistance program where if you hired, like let's say Christiana Health hired a group to do chronic disease management to help them learn how to do primary care behavioral health integration. You'd have technical assistance training and then continued follow-up with technical support to sort of figure out how you do this with administrators, doctors, everybody on the team, right? And you do this over a certain period of time. So we roughly mimicked that in the first condition. The second condition, we randomized organizations by type, right, to something called community engagement and planning. So what we did was we trained everybody up on the toolkits, and instead of providing technical support over a couple months, we brought everybody to the table in each neighborhood and said, let's plan together using this community engagement approach to adapt these materials to create a virtual depression network. Because one of the things we found very quickly was that there wasn't enough primary care, and this is before ACA, to even begin to meet the needs or formal mental health services. So we had churches, barbershops, beauty salons, and we invited, and patients and families, and we invited them to the table. And we said, in South Los Angeles and Hollywood, and engaged in a 6-month planning process, adapted materials, medication trainings to include things like prayer, complementary alternative medicine, because they said, you're not going to drug my community, right? Take something like care management, which is done in a clinic, and adapted for case managers, ministers, for them to identify, screen, educate people, and follow up around depression care. We adapted cognitive behavioral therapy for depression to be done by substance use counselors. In California, they're certified, they're not licensed, because that's where the capacity was. And we also changed something called that depression cognitive behavioral therapy model into something we like to call a resiliency class, which we're also now studying independently, where the partners said, depression can't be done, we don't want to call it depression, we want to call it resiliency. We want a 3rd grade level or below. We want it to be done by anybody who's an individual, who's like a good sort of a good teacher, and we don't want it to be therapies, and we want it to be able to deliver it anywhere, right? So we call it a resiliency class. We shortened a CBT manual that was the first manual that was studied for low-income African-American women and Latino women, and actually in the DC area was in JAMA by Jeannie Miranda. And she actually wrote the Surgeon General's report on minority mental health way back when Satcher was Surgeon General. And we've slimmed it down from about 16 sessions, 8 sessions to 7 sessions. And we adapted that in real time. And then we retrained everybody up. Once again, for this study, I just want to look if the papers will show this, but the RAND survey group went to waiting rooms and randomly sampled people. That's how we did this, because it's a cluster randomized trial, right? And we had, once again, 95+% of individuals that the RAND survey group approached in screening areas, in waiting rooms, to agree to be screened, and I think 95+% of those who qualified. And the criteria for entry were very simple: 18 or above, English or Spanish speaking, a PHQ 9 score of 10 or above, which is, as everybody knows, sort of the threshold for mild depression. And in the judgment of the people we're screening, we're cognitively there enough to sort of even be able to participate in the study. And then fourth, reliable contact information. That's it. And we had, I think, we were a year behind because of all the planning in RR1, but the NIMH was very generous, right? But we ended up catching up and actually being ahead by the recruitment process. We finished the recruitment in like 10 months or 9 months, and we were supposed to do it for a year. So we ended up catching up. The other thing that we had to do was the community partner said to us, so what about housing or homelessness? What about prison reentry programs, right? What about seniors? Rant survey group costs a lot of money. We don't have enough money. These individuals are really hard to track. Loretta said,
So what?
that's right. So we had to get another grant or two to actually follow this. And believe it or not, we actually were able to get some supplement grants right after the crisis. And also this took place in the 2008, 2009 when everything fell apart, right? And anybody who knows about organizations, right, trying to get staff members and organizations to these things, to participate in all this community engagement planning, how hard is it? It's impossible. But you know what? We had been there for so long, and actually we have another paper about this, participation in the trainings and engagement. We had rooms like this full of people, like monthly training conferences, and we didn't pay people a dime. Right?
What they received, though, was far more valuable.
That's right. Respect.
Respect, and they received all of them training material. No one walked away without the training materials, so they could take it back to their agencies, and they could train people within their agencies on how to screen for depression. And they also were able to have developed some of the resources and met the resources personally because this was a community event.
And we're going to probably be about 5 or 10 minutes behind. I apologize. But I think, so this is one of the way, this is from a planning event where we're adapting with the partners how to address, how to adapt these toolkits and sort of the way one did that. And this is actually Loretta's daughter, Felika. Why don't you play this video?
Story is we all came together around a pot of depression, right? We came around a pot of depression, and we all have something to give. We all have something to contribute to the pot to address depression.
Does anybody have some screening that they can put into the pot?
Could you come up here and put it in the pot so we can have some screening in our
Come
pot?
bring it on down, Reverend Stone. Woo!
We got some screening. Thank you. We're gonna have some screening.
And I believe there's a little bit of patient education out there. Let's get our patients educated. Woo! Starting to smell good, huh? All right, and I think we have some case managers out there. Let's get some case management up here into the pot.
Oh my goodness.
That's right.
I'm starting to drool a little. And I believe we have some outreach. Do we have some outreach workers out there? Woo. We need those, right? And I want the audience to shout out, what are some things that in your agency you can contribute? Cultural sensitivity, patience,
There we go. We need some that in this pot.
positivity. We heard positivity. Empathy. Commitment. Authenticity. That will complete our pot. And
I think
everyone.
What's the ingredient, Pastor?
Love.
And if you can hold fast to this idea that each of you have something special and distinct to add to a pot that our community needs very dearly. And only you can put it in there. See, the researchers can't do it. We can't do it by ourselves. The preachers can't do it. Our community is suffering from depression. And we all need to be a part of the solution. So I beg of you to stay involved, get involved, be committed, so we can have a healthy stone soup. Thank you.
So that was one of the planning sessions. And so what we did was we retrained everybody up on that. And what we found was that, well, remember, this is a comparative effectiveness study in its essence, right? Where you compare two things that you know kind of work, right? Aspirin, Tylenol for pain, right? What works better? This is two different ways of disseminating, implementing depression collaborative care. Both, actually, the twist is that between healthcare and non-healthcare settings, is that the community engagement and planning condition and the resource for services technical assistance, they both improve depression equally. But the community engaged condition was more effective than RS at 6 months at improving mental health-related quality of life with the SF-12 and physical activity. We reduced homelessness risk by about 50%, and we reduced behavioral health hospitalizations by about 50%, even among high utilizers, 4 more nights in 6 months. Why is that important? Because now it's going to end up having policy implications. I'm going to go through this quickly, but that's basically is, and if you want the citations, the Journal of General Internal Medicine. And one of the things we always like to do is we like to return the data back to the community in forms that they understand, and we have a conference yearly or every year, twice a year, to sort of work with larger groups of partners to make sure that what we're doing is relevant. And so this is one of the things that was funded by the NIH, National Library of Medicine, CTSI, to return the information back to the community. You can play this. This is Ken. He's very white. You want to play it?
Depression is real.
And is the leading cause of disability in adults.
It affects a person's productivity, their family life, and their communities.
It affects how you work,
how you love,
And how you live. But there is hope.
With education and quality care,
depression is treatable.
Quality care for depression improves not only the symptoms,
it heals family dysfunction, lessens homelessness, and helps a person find employment.
But there are barriers to getting high-quality care.
Especially in minority and under-resourced communities.
Because depression has a stigma.
People who have it and are treated think that others will see them as crazy.
and this makes it difficult to seek help.
So, how do we break stigma?
and bring quality care to the community.
By working with the organizations in these communities who have already earned the trust of depressed clients.
and that's just what we did. UCLA and RAND began with Healthy African American Families, Queens Care Health and Faith Partnership, and Behavioral Health Services.
Engaging their communities of South Los Angeles and Hollywood.
They recruited agencies from churches to senior centers to health advocacy organizations.
To primary care and mental health clinics.
Uniting with Parks and Recreation, substance abuse, social services, and homeless agencies.
Even barbershops, beauty salons, and fitness clubs.
95 agencies to be exact.
Together, we became Community Partners in Care, CPIC.
So, how did we do it?
By creating training and programs together.
To think of depression as a community problem.
Rather than a primary care problem.
Guiding over 500 providers through more than 100 conferences and trainings.
People really grew together.
And the results were amazing.
Mental well-being and physical activities in these communities improve.
Visits to faith-based settings increase.
The risk factors and numbers in homelessness decrease.
We reimagined depression care by providing services through the local organization.
Improving lives.
Bringing families and communities together.
Depression is treatable.
And the stigma can be overcome.
We're building a community from the community.
I'm in the community.
I'm in the community.
I'm in the community.
I'm in the
I'm
community.
in the community.
I'm in the community.
I'm in the community.
I'm in the community.
We are community.
Community Partners in Care.
CPIC.
Join us in beating depression.
So, this is an example of how you disseminate things. I'm going to go through some of the other slides very quickly so we can get to the key exercise so we can stay on time. So these outcomes persisted, the mental health related quality of life outcomes persisted for the community engaged group at 12 months. And depending on how you do the analysis, those damn outliers, and there's some suggestion that continue to reduce it at 12 months. And this is in the Annals of Internal Medicine. We won a lot of awards. We're very fortunate. The 2014 Association of Clinical Translational Science Award. We're the first applied team to have won it. That's, as everybody knows about the Association of Clinical Translational Science, it's very basic science oriented, or maybe translation says that's a big deal that we were able to get there. We won the 2015 Campus Community Partnerships for Health Annual Award. So this is an international award for adherence to good examples of community campus partnerships. And UCLA, the Chancellor's Office there, named us the 2015 Community Program of the Year. We've had funding from all these lovely organizations. This is our team at the beginning. We've had some work, continued work funded by PCORI, both for long-term follow-up with the Community Partners in Care group, and we actually have a randomized trial of that resiliency class we're doing in New Orleans and LA with LGBT groups. And one of the important things about all of this is that the Community Partners in Care had originally a usual care condition, and our partners said, no, we can't do that if we know this works. Once again, with this other randomized trial, we're actually comparing depression technical assistance at an agency level between healthcare and non-agency healthcare agencies, and we're looking at the added value of this essentially lay health worker delivered cognitive behavioral therapy group or class for LGBTQ individuals, and that's currently in process right now. Once again, all of our studies have had 95+% of people we approach in the community agreed to be screened, and 95% plus. Actually, the last study that preceded this, which I didn't include, we had 100% of 325 people in churches, adult day schools, primary care, 100% with demographics about 98% African American, Latino, 70% under the federal poverty level, agreed to be screened. 100%. We finished a randomized trial of our initial randomized trial of a 7-session resiliency class in 5 months compared to case management. So one of the important lessons for clinical translational science institutes or investigators is that, you know, a lot of literature talks about how much time it takes, but if you actually allow a partnership to mature like we have, you can actually accelerate it. And you should really treat it as a protected infrastructure, just as you would an MRI, right? Or a genomic sequence analyzer. I don't even know what they are anymore because I'm so far away from it. That is, it's an important infrastructure that can accelerate the translation of science, right, to improve racial and ethnic disparities in health, to help individuals who are the least among us, right? And the policy issue, and to translate it, so as a result of our work, because, and this gets back to why I'm a county employee, the county supervisor, so in LA County, in California, we have counties. We don't have, cities actually don't do as much. And there's 5 supervisors in Los Angeles. They don't agree on anything. Seriously. I think if we were its own state, would be about 11th in the country, about 10.5 million people. They put this as a new way of delivering healthcare because this started gaining relevance under healthcare reform, right? How do you do ACOs? How do you decrease costs? How do you engage people who aren't engaged? How do you increase patient satisfaction? And they included as part of the strategic plan to do something like this. We're actually very soon, we're going to be doing this in New York City with the Medicaid waiver there, where we're working with, I think currently about 3 health systems, where discussions about doing this in real time, trying to figure out how to do this, community engagement and planning. So, and the reason why is because there's some suggestion that it reduce costs, and I'm not going to go into all that because we don't have time. But one of the things we like to do at the end is we always like to do these community engagement exercises. They're like corporate warm-ups with the community. And so I'm going to let Loretta do the last bit, and we're going to be done.
So, everybody, how many people have a key to their something? Does anybody in the room have keys with them? Okay, all of you have keys. Can you shout out what your keys are to?
Here, I'll go. I'll be Phil Donahue, and I'll do my lab.
Okay.
Yeah, wait, hold on. Omar gets it because we talked to him on the phone. We got to know him. So show me your keys. We got to show you. You got to show us keys.
A lot of people don't carry keys anymore.
Car keys.
Oh, so you have a nice ride? You got a nice ride?
I like to think so.
Oh, he likes to think so. Good.
Okay.
What do you have?
House keys, office keys. I actually don't know what this key's for. I realized when I picked it up, I have no idea.
So you have a house, and you've got a job. That's amazing. Anybody else? I'm going to go over there because why not? Who wants to show me their keys? Raise your hand. Okay. Key, what do you got?
So I have car, office, house, and my daughter's house.
Ah, someone trusts you.
So your daughter trusts you enough to have her keys. You shouldn't take that for granted, right? Right? Yeah, well.
Other keys?
Any other keys? Come on, don't be shy. This is the fun part. Oh, thank you so much, ma'am. And I'm going to walk over there. And we actually do this kind of thing, and I'm just sort of mimicking what we would do at a community conference when we do these kinds of things. Yes, ma'am.
Church, house, daughter's house, hospital.
Wow. You got, they trust you at the church to have the keys?
Two churches.
Wow, she's trusted at 2 churches to have keys, and she's got a daughter, and she's got a job. I would imagine you work in healthcare?
Yes.
What do you do?
I'm a faith community nurse.
You're a faith community nurse. So she's doing well. She's got a job, and she's got lots of people who trust her. And so I think at every table we have blank keys.
Oh, there's every table there are blank keys.
So everybody pick up a key.
Everybody pick up a key. And I'm going to tell you a little bit first, because some people didn't say anything. How many people have loyalty keys on their keychains? Where you where you go to the grocery store and get those discounts. You know, and there are other keys, mailbox keys, so you have a place to pick up your mail. And there are other places where there are keys. Now I want to ask you, just to shout out to me, who has no key? Homeless, okay? Children, okay? People with disabilities. Okay. People in nursing homes. Oh, yes. Yes. Now I'm going to name off some other people who have no keys. People who have no access to good health care. That's a key, right? What about education? In communities where children don't have pencils and paper and books. They have no key to access to good education, right? And there are other keys that are missing. So I want you to think about the keys that are missing and the people that are missing with those keys, so that when you're sitting at a table, you should put this keychain on, this key onto your keychain, and you can think about it when you're sitting at the table. Whose voice are you speaking? Are you just talking for yourself? Or are you talking for those people who have no voice? And if you're talking about the people who have no voice, that key on your keychain is a reminder, because we forget sometimes who we're supposed to be responsible to, not just where our money comes from. And that's an important piece. And in community engagement, this is critical. So that it's critical not only for the community to be able to say, I'm talking for these folks, but it's also critical for the academics to talk about how this affects them as well.
So we're doing this, it reminds you that we're working for people who don't have keys. And that the end beneficiary in the end should, especially if you want to push to, population-based impact of transitional science, is to make sure that this work is done for people who don't have keys.
We want to thank you for listening to us this morning, and we're sorry we ran over by almost 10 minutes.
Yes.
We apologize.
We apologize, but thank you so much. Oh, okay. Oh, we have questions. I think we may have questions.
Questions? If you don't, I'm going to give you a test.
Roving microphones around as well. So if you have a microphone that folks have access, just raise your hand. A couple folks around here microphone.
While you're waiting to get your questions, I'm going to tell you one of the things. The model that we have, that we've been using for years and years, you can find it actually in a JAMA article that we wrote in 2004, I think it is.
Actually 2004 and 2005.
2004 and 2005. But it's looking at how do you develop the goals together? How do you do the planning together? How do you define the roles of a responsibility and decision-making together? And then how in the world do you disseminate this together? And that's required by all partners. And that's one of the ways that we've done this, so that we can keep everybody honest. Now, questions.
I have a question. So you said, I think very eloquently, that you wanted the NIH to look at this partnership as an important piece of infrastructure, and to kind of say, hey, don't push us, let us take our time and build this. because in the end, it'll, sort of trust us. In the end, it'll be okay. I'm sure that you encountered some internal doubt
And external.
and some as I was gonna say, some big external pushback and doubt on that. How did you face it? And
Well, the first thing we did was we worked with Dr. Zahuni. I don't know if anybody remembers who Dr. Zahuni was before Francis Collins was the director of the NIH. Dr. Zahuni was. And one of the things Dr. Zahuni had was a council of community that he spoke to on a regular basis. And this is where we talked about the pushback of, why are you doing this research that has, historically, you keep going over the same research and you're not getting the right answers because you're not talking to communities. And so we pushed and pushed, and finally he was the one that said, okay, I think I understand a little bit about what you're saying. Come talk to us. And so we spent a lot of time talking to NIH until NIH said, we have a new idea. We're going to talk about community engagement. And then they did some RO1s and RO21s, and they said, community, we want you to come and film for us what an RO1 and RO21 should have as community engagement. And today, even, they still have those videos in their library that you can go and check out by going in there and looking for Loretta Jones and Ken Wells, or Loretta Jones and Keith Norris, and you'll find them. And they're there.
Yeah, I think, as somebody who's kind of been more of the junior investigator, they tell junior investigators never to do this. I think the first thing is that, it's commitment. So there were times when I didn't have funding, and my partner stuck with me. My first major paper, we had dinner at Ted's house every couple weeks to review the data and the paper. About 10 of us, we cooked dinner, and people continued to meet. And when the community partners didn't have as much money, I found ways very creatively to get grants. Wrote about 100 letters of intent to different local foundations, and sort of pieced together things until we got federal funding or PCORI funding or RWJ or California endowment type funding. But I think the key there is that it's adhered to the principles of commitment. And if I'm committed, everybody else is committed. I think it still works. And what? Yeah, anyway.
Other than depression, were you able to interact with and include people with other disabilities and provide accommodations and access for them to be part of all of your research projects?
One of the things that we've done is that as soon as someone has raised a barrier, we have looked to solve it. So we always meet in places that are disability focused so that people can have access. So we never go to a place to have a meeting on the second floor where there is no elevator. We always allow people who are depressed to come to our meetings, substance abusers to come to our meeting, the homeless people to come to our meetings. We always allow for the languages. So we actually do translations, and we have translators from the communities, and we have translators from the university. And we actually go and access the equipment in communities and pay that high price. I was going to say a bad word. We pay this high price to use their equipment sometimes because communities can't afford to buy equipment for translation. So we have to rent equipment. And so we've used that to take and make sure that whenever we have a workshop or anything, that we do it in Spanish and English, Spanish, English, and Korean, Spanish, English, and Korean, and Tagalog. I mean, if you name it, if people come, we do it.
It's like the UN where people have these headphones on and they do real-time translation. And we've been able to get equipment from the city and the county to do that in real time.
You have to rent it, though.
You have to rent it.
Is that helpful?
Yes.
We work hard at that so that we actually have a program called Resiliency in African American Men where we've actually brought men to the table to ask them, what are your issues and how should we address them? And some of the things that we've come away with were striking. Why do you want to talk to us? We don't know anything, and you're going to do it anyway on us. We don't trust you. You want our DNA so that you can take and arrest us. So we've had to take and go through those barriers, but at the same time, we've had to take and tell folks, when are you going to take and open up a clinic that's at nighttime and on weekends for those people who have hourly wage, who can't get and sit in your clinic all day long and sit in a chair that was made for women?
Yeah, it's actually men with depression or just in general with health is the disparity population, minority men in particular. And you know, in all of our studies, it's been about 55, 45%, 60%, 40. So we've done pretty well in engaging men. Loretta has had a continuous group meet for over 10 years, and we have some work that we've done with African American men in particular that we didn't talk about here, but we've worked in that area quite a bit. Not as much, it's been variably grant funded, but maybe that's the next grant. They have actually. She has a pipeline to proposals, a Pcori grant to support that work right now.
Right now.
Okay, thank you.
Thank you so much.
We appreciate it. Thank you.
Thank you so much, Bowen and Loretta. Thank you.
Thank you.
Thank you. That was wonderful. Thank you so much.
Oh, I'm so happy.
So we are actually staying right on time because we built the correct amount of time in the program. Oh, that's okay. It won't be the first time.
Okay, thank you.
So we have kept the correct amount of time in the program. So we're going to simply move the next session to from 9:30 to 10:30. So we're staying right on time. I want to introduce our next set of folks. But before I do that, I just want to mention that Bowen and Loretta's work is going to, the conversation is going to continue. I hope you enjoyed their comments. I know I certainly did. I have a new key on my keychain as of 5 minutes ago. So thank you for adding to my mental models. They're going to be part of our afternoon panel discussion as well. So please keep your questions for them during the break and during the panel as well. Our next session is going to focus on some of our terrific Excel-wide research projects, and that'll be introduced and moderated by Dr. Heather Bittner-Fagan. Dr. Bittner-Fagan is Associate Vice Chair of Research in the Department of Family and Community Medicine at Christiana Care. She is a family physician and an accomplished researcher with a record of NIH and Foundation grant funding. She is also the component head for the community engagement and outreach component of the Excel CTR. And she's a personal friend and colleague, so please join me in welcoming Dr. Bittner-Fagan.
I take special pleasure in introducing this panel. I've had the privilege of working with each of these teams and share the hope that fast forward 10 years and they'll be up here presenting much like our keynote speakers were. Now, I don't see, I have not laid my eyes on Dr. Dodds. Okay, there you are. Okay, you're just kind of stuck behind. So if you want to come on and make your way up, the way that we're going to do this, it'll be a little fast and furious. We're going to have our teams present for about 10 minutes, and then they'll get their 5 minutes of questions. So Dr. Dodds, Dr. Gellert-Jones, and Ms. Gallagher, am I right? Dr. Gallagher? Yeah, Dr. Gallagher, Ms. Gallagher. Okay, sorry. They work with severely brain damaged children with multiple disabilities, trying to come up with a tool really to measure responsiveness and to adapt that tool actually in the clinical applied world. So without any further ado, I will hand over.
Hi, I'm Mary Ann Geller-Jones, and I'm thrilled to be here today to present our project, which is the validity of the pediatric awareness and sensory motor assessment involving academic and community investigators. My colleague in this is Diane Gallagher, as a fellow community investigator who's the director of HMS School, where I'm from, and also Dr. Cindy Dodds, who is from the Medical University of South Carolina, which is the largest non-federal employer in Charleston and has almost 1,500 faculty. So we're very happy to have all of that support for her. And I come from HMS School for Children with Cerebral Palsy, which serves approximately 56 children with severe medical complications and severe central nervous system impairment. Our school is a day and residential school, serving children primarily in the tri-state area, but we serve children across the country. And we provide a full range of special education programming and full therapeutic services, as well as comprehensive nursing care. So we have no financial relationships to disclose. Are our slides running? Sorry, can keep on going. There's our school. And, oh, yes, I do, I'm sorry. There we go. We have no financial relationships to disclose. And our work is supported by these grants. So who are the children that we're looking at? We are looking at children who have a gross motor function classification of a level 5, which are children who are fully dependent for mobility, activities of daily living, and are primarily nonverbal, so they're fully dependent for someone to interpret their communicative intent. This is approximately 4% of the 13 to 18% of children with special, who are classified with special health care needs. And why did we want to investigate these children, and why would we need the PASMA? Right now, there's no ideal way and no real formal way to measure the baseline functioning for cognitive levels of children with these kinds of severe brain injuries. Most of the time we do kind of narrative assessments, and most of the time what we're doing is sort of gleaning what we think we see, and we can't really get baseline scores on them. There's nothing that exists out there to serve these children. So the Pediatric Awareness and Sensory Motor Assessment was created to measure and assess these children and gain baselines. And we feel that with a study, testing tool like this, that we would be able to develop a baseline and then also improve quality of life and participation in programs by better understanding these children. So our research questions, what are we seeking to answer? First is, does the PASMA actually meet the characteristics of a meaningful measurement tool? And second, do the scores from the PASMA correlate with those obtained on the closest measure available for this population, which would be the Pediatric Glasgow Coma Scale? And then third, we actually are measuring heart rate variability in the students that we're assessing, and we want to see if there's a correlation between what we're observing and during the responses elicited during the PASMA administration, and see if there's some kind of physiological change that we could measure as well. And fourth, do we achieve actually good to excellent inter-rater reliability, and also are we able to advance the community investigator skill set in research? So those are the four sort of main research questions that we're looking at. Our purpose is to continue to look at the validity of the PASMA and investigate the correlation between the heart rate variability and the Pediatric Glasgow Coma Scale. And then also to train me as a community investigator to be a reliable administrator of the PASMA assessment and an interpreter of the findings that we have. How do we plan to do this? Well, we have a target population of 15 children with severe brain damage who meet the criterion of our tests, who are between the ages of 3 to 21 years of age, are medically stable with physician permission and parental consent. And then the way we administer the test, initially we are watching them for 5 minutes with a baseline observation to sort of gain some understanding of the child's common motor output. And then we're evaluating their sensory motor responses in 5 sensory domains. And then after that, we're looking at the scores, and then the heart rate variability will be assessed as we go further to look at that with the data that we've gained in assessing the students that we've been looking at. So Dr. Dodds will take over.
Thanks, Marianne. I'm Cindy Dodds, and I'm going to move us forward a little bit. We're early in our process. We've only completed phase 1 of this grant, but I just wanted to talk a little bit about the statistical analysis. You can assume that we have an N that's very small right now. Our N is only of 8 participants. We hope to have 15 by the end of June. So we're going to have a small N, and you can assume in some of the reliability data that I'm going to give you in a few minutes that my P is less than 0.05. So we're using Cohen's kappa coefficient to really look item by item at Marianne and I's reliability. Eventually, we've done some preliminary rationalisis to kind of look at the construct validity, or really the item person fit and the item difficulty level. But that's really early, and we're not quite ready to share those findings. But we will probably be within the next 6 months, have an idea about those. Eventually, there will also be some correlational data between the items on the PASMA, as well as the heart rate variability data, as well as with the pediatric Glasgow Coma Scale values. But again, we're early in the process. We're not really ready, and we don't have a super large N yet, but hopefully we will. Engagement plan, our phase 1 is completed. Basically, in phase 1, we obtained IRB approval. This also allowed Mary Ann to function as the community investigator who really sought informed consent and HIPAAs from the actual parents of the children attending HMS school and participating in this study, which made my life in Charleston, South Carolina a lot easier. I will say that. We actually did our first round of data collections from November 28th to December 9th. I was in Philadelphia, and I walked to the school every day, and we did assessments all day long. So we assessed 8 children. It's 5 assessments per child within 10 days. So we were pretty busy, but we got it done, and I was impressed. This was also an opportunity for me to start training Mary Ann in the actual administration of the PASMA, and it also gave me great value in the fact that Mary Ann, I'm a physical therapist, and Mary Ann is a speech and language pathologist. We come and look at the world very similarly, but yet very differently. It also gave me valuable input as to how we may adapt this assessment into the future. We were able to establish some reliability data, and I'll share that with you in a few minutes. We did collect our scoring and our data through iPads, and we did that through a RedCap app for data capture. So that has been a really good tool for both of us, and you'll see in a few minutes we've been able to use it for other purposes related to HMS school as well. I'm not going to read all of these to you. Again, I just remind you that this is just a very small N, and we are early in the process, but these are the 5 domains that each have, it can vary from like 4 items to 12 items, but if you look, we had 100% agreement between Mary Ann and I within the olfactory section. Our auditory section was probably our weakest. We had kappa values of 0.2 to 0.5. That has allowed us, we're pretty confident on how we can change administration to improve our reliability on this on this domain. Within respect of vision and the gustatory and the tactile, each had 1 item that was really below 0.4 or so, but all the other items were really above 0.5 to 1. So we really had pretty good agreement, considering that we had an N of 8. We didn't do too bad for a small team in our first time out of the gate. So I'm pretty pleased with that. There are kind of collective summative scores where we take the raw data and we can look at ICCs. When we look at the domain total scores, our ICCs were all pretty reasonable as well. Our phase 2 agreement is our return to Philadelphia in 2 weeks for 2 more weeks. We already have 7, Marianne already has 7 to 8 more children that have consented to participate in the study. Recruitment has been super easy. Families are very eager to learn a little bit more about the strengths of their children rather than always talking about their deficits, and we both feel like this is what this tool may offer. We will then follow up with more formal reliability assessments as well as look at the rational analysis. Our phase 3 will be dissemination. We will clearly disseminate to the parents and the HMS school community as far as what our findings are in this group of children, and we plan to eventually move into manuscript submissions and hopefully acceptance. Our collaborations, I can't tell you how easy they have been. I felt like I was at home the minute I walked in there. I met Diane Gallagher, who is executive director at HMS at another Excel event, and it's just been kind of like a match made in heaven, and I can't say that more strongly enough. Marianne and I had hoped to talk at least once a week. I'll be honest, we're lucky if we can get 1 to 2 times a week. 1 to 2 times a month. Part of the time it's my fault, part of the time it's her fault, but we seem to kind of manage and communicate, I think, to as best as we both need. I'm a pretty firm believer that I want to get what I need, but I also want to give back to HMS. So we actually, Marianne's using REDCap now through my ability and her ability to do some feeding trainings, pre and post tests. We've also submitted and had 1 acceptance to American Academy of CP and Developmental Medicine about their feeding program. I'm happy to be involved in that process, although it's not directly related. I think it's important to build community relationships that I help them with what they need help with as much as they help me with what I need help with. We have 2 potential grants, one we're working towards submission. One is an NIH grant that we hope to look at art-based interventions for this population of children, probably a deadline in February, and then Marianne, I'm helping her also with a private foundational grant towards to help support the HMS feeding program. And that is all we have. Do we have time for questions?
So Cynthia, I know that you guys kind of had an inverse challenge in that when you first started talking to me about your project, you mentioned that everybody wanted to participate, that you really felt like the parents of these children were so eager that your fear was almost the opposite, that you might not be able to. So I just want to bring that up and hear you comment on how that impacted your work.
Well, I probably, not my direct work with HMS. I think they were lucky and I was lucky to find each other. They had some of the resources, they had some of the wording, like city training was not foreign to them. Diane Gallagher, executive director, has a PhD, so we could talk in the same language, which was very helpful. What worried me after my 2-minute presentation at another Excel event, I just got bombarded when I got back to Charleston. I had early interventionists, other therapists traveling throughout Delaware, especially I had more on the Nemours side of things, contacting me, wanting to be in the study, and it was great, and I would love to help everyone, but it wasn't doable with the money I had. But I do think what it did demonstrate is as I move forward in larger funding, there's just such a need. There's an educational collaborative, and they're desperate for assessment tools to measure this population of children. I don't think we have a magic bullet. I think Marianne and HMI, we're just trying to maybe throw a little dart at the standard of care for this population. This assessment is not, it's not going to fix the level of brain damage that these children have. It's just not. But can we do anything to improve their quality of life? And have a feeling it's pretty much a national issue, not just a Delaware or South Carolina issue.
I just wanted to commend you on the fact that you said that you did something for community that was not a part of what you normally do. That is very important when you're doing community engagement, is to be able to give back to community something that is very different than what you do on a daily basis. I want to thank you so much for saying that.
I think for me, it's not really about my work per se. It is about, I really am here to serve this population of children and try and move the standard of care. Marianne's work is doing that as well as my work. So I'm all about anything to help do that. So thank you. Oh, do we have time? Oh, no, that's fine. I just don't.
All right, we're gonna keep things moving along here, and Laura and Kathy, if you guys want to come make your way. Our next team is going to talk to you about something that is sort of a classic of what we want to happen in translational research, and that's, someone created a really great evidence-based strategy to do something, and we can't let it stop there, right? We have to be able to move it out into all the communities that need it. So I will let Laura Dewey and Kathy Rose speak to you about that now. I'll give you 5 minutes from my seat, and then
and I can move forward. Good morning. So I'm Laura Dewey, and I'm a psychologist at Nemours, and this is Kathy Rose.
Kathy Rose, I'm a clinical director at Delaware Guidance Services.
And so what my work is at Nemours is I'm primarily an autism-focused psychologist, and so really trying to serve the autism community in Delaware. What was unique about this project is that actually Delaware Guidance had approached Nemours to say, we want to be able to serve this population of children better. And that was before we even applied for the grant. And so it was really nice that connection was made, because that let us know, okay, there is a need in the community that Delaware Guidance has identified, and so how can we partner as the expert clinicians at Nemours to really help Delaware Guidance and the community serve this population. And so autism spectrum disorder is at its core a social disorder. It's considered to be lifelong. And so one thing that we know that families often ask for is social skills support, which is very challenging to do for families in autism, because the social piece of autism is not really going to get better or be cured or be solved. However, there are ways that we can support the family and improve quality of life for the family. And so we know that this is something that families are looking for. The state of Delaware had a HRSA grant in 2012 to create a blueprint for autism care across the whole state of Delaware, and the need for social skills training came from that. As most of you know, DuPont Hospital is in Wilmington, Delaware, and that is not where most of Delaware is located. So ways that we can get these interventions into the community is very important to be able to serve these families. So the engagement plan was to build capacity for social skills interventions for autism across the state. And so our plan was, we knew we had great partners with Delaware Guidance Services, which is a community mental health agency, and they have different locations across the state, including in Dover, and in Lewis and in Seaford. And so we wanted to be able to partner with them to help their clinicians have the skills that they needed to support these families and to do social skills programs for children affected by autism. So we selected PEERS, which is an empirically validated social skills intervention from UCLA. It's a clinic-based model that has 14 weeks, which is a big commitment for families, but it's only been done in clinic settings. You can buy the manual online, but really it's been used like in hospital-based clinics. It has not been used in the community, so we thought this would be a nice opportunity to train community providers and to see if this type of intervention has the same kind of efficacy in the community as it does in more of a research-controlled clinic setting. So our aims of the study was to build capacity for autism interventions by providing formal education to clinicians on PEERS, And then we wanted to look at similar measures that peers did in the hospital setting, so looking at social skills symptoms, parenting stress, and then we wanted to add the family quality of life, and that is something that has not been studied in social skills interventions as specifically as the social skills symptoms. So we're using some of the same measures that the original research studies in the hospital-based settings have used, and we'll be able to see if we're getting similar outcomes in the community, as well as adding some of our own measures, the stress and the quality of life, because those are factors that qualitatively we see move in families that have not been studied as specifically. So these are our basic aims. We wanted to do training for clinicians at Delaware Guidance, and then we were going to run 2 cycles of peers groups in the community. Each group can hold up to, we were thinking about 10 children per group, or 10 children or families. So we could have up to 80 families participate, and we'll give you an update on where we are with that. And then caregivers were completing pre and post surveys about parenting stress, the social skills, and the quality of life. So for the first aim, we did already hold our training. So we did that in November of 2017, and we had over 25 staff from Delaware Guidance participate. We were able to have a whole morning session with myself and with the director of several HRSA grants and state-funded support for autism in the whole state of Delaware attend and provide that training. And we did pre and post measures of the clinicians. And then we are currently in the process of running the social skills groups. And so I'm going to let Kathy talk a little bit about how that has been going in the community.
So we've finished a first round of groups in Seaford, our Seaford Clinic, Dover Clinic, and Lewis Clinic, and are starting new groups in Seaford and Lewis. The barriers, one of our primary barriers has been staffing the groups. We've required 3 clinicians per group to run the groups, and so that's been a bit of a barrier, as is some recruitment of clients. But the groups that finished first had a great time. One of the really nice things takeaways for me has been the parents were able to come together as a group and share a lot of commonalities for that age group. What they're reporting is that when they go to support groups for autism, they're often mixed with the groups of people who have younger children who are just discovering how to manage behaviors and school issues and that sort of thing. This group of parents have been dealing with their autistic youth for 10 years, 12 years, some of them 15 and 16 years. So when they came together, they had the same concerns, which included the bullying issues, puberty, and just basic socialization. So it was really awesome to see these kids and these families kind of come together and share experiences as part of the homework in the group. They had to engage outside the group, and the parents really got involved in that, so that was really great. They all want to come back for a second group. We haven't figured out how to do that, but both the kids and the parents are wanting to be part of that. And last week in Lewis, as a new group of mostly 10 and 11-year-old boys, there are 9 of them, a young lady who was in the previous group wanted to help support them with their first group. So I think the clinicians allowed her to come in and be a mentor for them. So that's the anecdotal experience of the group so far.
Thanks, Kathy. I think. So just to wrap up, I also wanted to mention as well that this partnership has been very powerful because there have been several statewide initiatives to serve children and adults and families affected by autism through, I think there's a 3-year HRSA grant right now, as well as the state legislature has actually funded the Delaware Network for Excellence in Autism. And those initiatives, Nemours has been very involved in, but we are also really been able to push in the community. So I've been talking with Kathy about they want to expand the services that they're offering to children affected by autism. So there are ways and mechanisms through the HRSA grant and through the DNEA and through community partners like Autism Delaware to really start filling some of those gaps. And so having this relationship and being able to start this process is really facilitating movement forward with making sure that we're expanding autism services throughout the state. So that has also been very exciting. And so now we can do questions, if that's okay, Heather. Thanks, guys.
Oh, hi. Thank you. And, you know, my day job is a child psychiatrist.
Yes.
So this is, and I don't see as many patients anymore, but one of the things I've become particularly passionate about and don't know anything about is the health and dental needs of this group of individuals, particularly as they get older. They're great when they're cute and young, or kind of cute and young, but when they enter their 20s, 30s, and 40s, one of the big gaps I see, and I was wondering if the parents ever talk about this, is a chronic disease management for things that they become obese because of antipsychotics, diabetic, and the biggest gap is in dental care. And I can't tell you how many kids I've treated with Risperdal for an abscess in the tooth because they were banging their heads against the wall. Has anyone ever asked about this? And no one's doing this, by the way.
So I have a couple thoughts. So first, one of the, at Nemours, not Delaware guidance, if we can help with some of these behavior management when they're children, we're hoping that by the time they get into their 20s or 30s, the dentist is not going to be something that's an issue anymore. So we can work with a 5-year-old, a 6-year-old, we work with a 3-year-old to really help them become desensitized to that process and used to that process from behavioral interventions. And so I think that the more that we can have interventions targeting families and targeting parent training and supporting our community partners, my hope is that as we move into the future, these families are going to have the support and the skills they need to manage those behaviors later on. So that's my first thought. The second one is, yes, I hear about dental care all the time. And I think that it is a big gap, especially in Delaware. For a while, Nemours had their dental program closed down, but it has recently reopened. So we are getting a lot of referrals that we were getting before, and we are, as we're building our autism program at Nemours, trying to incorporate the dental piece into that so that that is not a gap for families. It's something that we can support. And then, but if you're asking about, what about the individuals right now that are 30? What are they doing for dental care?
Come up in some of the discussion.
And I will, have you heard of this from parents in the groups, Kathy, asking specifically about dental care?
Not so much, because most of their children are younger and are actually getting the care. I think there are a few older. One family, they had two. The first group, they had two, the younger children, and they have an older son who's like 23. I think he has some health and dental issues that may not have been addressed. But other than that, it's.
And the University of Delaware, one of our mentor on this project is Brian Friedman. He's a psychologist in the Center for Disability Studies here at the University of Delaware. And he is also acting as the director of the DNEA, or the statewide Technical and Training Institute for Autism. And the expertise through the Center for Disability Studies is with adolescent and adult transition care. And so if anyone was really interested in what should we do for a 20-year-old that needs dental care, I can help you find an answer to that, because I think that Dr. Friedman would have some ideas, and the University of Delaware has been a big support in figuring that out.
Hi, this is a great program, and I really congratulate you. As you continue, you're going to find that some families and some individuals do better or worse depending on the outcomes of your program. Are you planning on looking at individual differences in outcomes based on either family or individual characteristics to see, because obviously a one-size-fits-all isn't really going to work. So are you going to be looking at individual variations in outcomes and how you can better the program?
That's a great question. So the it's interesting because even in the peer social skills program, that this one is one social skills group that actually has empirical evidence. Many do not. And the measure that they use, it has a clinically statistical significance of decrease at the end of the 14 weeks. Clinically, it's not meaningful. the social skills are still incredibly impaired when you look at the numbers, which I find interesting, which is why I think looking at the quality of life in the family and exactly what Kathy is talking about qualitatively, how do the parents feel in being able to manage their child moving forward, I think is a huge piece of the puzzle. The other part that we wanted to look at, this is a little bit different than individual differences, but looking at what are the families reporting as barriers, because we know that retention in these programs and attrition is high. 14 weeks is a huge commitment for these families, and I think that's what we've really found in the community especially. And so what are those barriers? And so we have families are filling that out pre and post, childcare, time of day, transportation, cost, co-pays. So we have a bunch of those listed, and I think that we're going to look at that, and that might help us determine within an individual family whether or not we're seeing differences in outcomes. If that answers some of your questions.
So apparently there's a bit of fake news in our conference brochure. We will not be hearing from Dr. White. She's very graciously and in a true community engaged fashion really asked other members of her team to come up and present today. So we'll be hearing from Anaya Coley and Jane Bowen about long-acting long-acting reversible contraception, for those of you like me who stumble on LARC, which has become a really increasingly important and key discussion here in Delaware.
Hello everyone, my name is Anaya Coley, and with me I have Jane Bowen and Jeanette Fenimore. You can go.
Okay, good morning, everybody. Thank you so much for having us. A couple years ago, Dr. Krishna White came to my office and we started discussing ways to better serve adolescents around the LARC initiative, and recognized that though adolescents can access reproductive health care confidentially at 12 years old, we recognized that in order for the statewide initiative to be successful, we really needed to embrace parents because we recognize that parents are the primary educators of their children, and that children really do depend on the support of their parents for their decision making. So then this grant opportunity came to us, and we're very appreciative, and we're going to talk a little bit about the research that we have engaged in. We've not completed it, so we'll just discuss what we've done thus far. And, let's see. There we go. So we have no financial disclosures to communicate here, and our work has been supported by this grant. As I said, we're very appreciative. So as you probably know, teen pregnancy has declined nationally and in Delaware, but it still remains a problem. So 46.8% of Delaware teens have had intercourse, and almost 73% of those sexually active teens have not used a hormonal method of birth control. And teens in Delaware have the second highest teen abortion rate in the United States. So yes, we have made improvements, but there are still some significant improvements that continue to need to be made. When we look at birth control methods, we look at it from a tiered vantage point. And LARCs, long-acting reversible contraceptives, are the most effective form of contraception. And for those of us who have been in the field for a while or have been on the planet for a while, remember that decades ago, long-acting reversible contraceptives were not recommended for adolescents, but now they are recommended as the first tier, the most effective form of contraception for women of all ages during their reproductive life, including adolescents. So when we talk about LARCs, we're talking about the implant, which is now called Nexplanon, and we're also talking about IUDs. Delaware Can is an effort that has been embraced by the state, and Upstream is a national organization that has come to Delaware, and Delaware is actually the first state that has embraced this initiative statewide. And there is a statewide partnership with Upstream, and the goal is to increase access to the most effective forms of birth control throughout the state. And the objective of our research was, number one, to reveal, to understand the current knowledge, the attitudes, and the preferences that parents of teens have about LARCs, and to understand the parental preferences about the use, and when we say access, where they would like their adolescents to access this line of contraception. And after our research is completed, our goal is to disseminate these research results to healthcare providers throughout the state, policymakers and educators, so that we can all understand how to make this initiative as successful as possible and give adolescents the access that they need and deserve. So this is a participatory action research initiative, and we have obviously been emphasizing the importance of gaining information from our community members. Our team involved Dr. Krishna White from Nemours. I am the program manager for Adolescent Resource Center with Children and Families First. Anaya is our study coordinator. Jeanette and others are community researchers, and we had invaluable help as well from some pediatric residents at Nemours. Phase one of our research involved first recruiting community researchers, and then we held stakeholder interviews. So we interviewed administrators, managers, medical providers from different community organizations and statewide organizations to get some information about what they were doing in terms of inserting LARCs and what their perspective was, what barriers existed for them. Phase two, the first part of phase two was we held focus groups statewide, and we also designed our statewide electronic survey. And the survey that we designed, which is now being completed, so we're in the process of getting those surveys, in the hands, so to speak, although they're electronic, so they're not really in people's hands. The survey was based on the findings that we got in the focus group. So there are general questions in the surveys, but then we also focused specifically on the concerns that came up during the focus groups. And we will present the results in a variety of settings. I'll be presenting at the DHMIC conference, quarterly meeting in June. I'll be presenting the results of our survey. And we are obviously distributing this electronic survey to parents of teenagers. Our focus groups, we held 4 focus groups statewide, and our focus groups were individualized toward families and parents who were of a specific race. So we did 2 focus groups for white parents, 1 for Black and 1 for Latina. Those focus groups were led by 1 or 2 community researchers who matched the ethnicity of the participants. We created a 36-question, semi-structured discussion guide. Of course, structure is a loose term when you're conducting a focus group because people went off on their own tangents and told stories, which was very valuable as well. And we fed the participants, which is always a good draw, and gave them a $55 gift card. 2 of our researchers used a values coding process to code the data independently, both manually and with the NVivo 8 system. And as I said, the REDCap survey that we're currently disseminating was designed from questions based on focus group themes. And we're recruiting participants via flyers, via email, and participants will receive a $10 gift card for completing this survey. And as of today, we have 138 parents who have completed the survey.
Hello, my name is Jeanette Fenimore. I was one of the community researchers who was recruited to participate in the project. The demographics of the parents that participated in our focus group, we had 90% were female and 10% were fathers or male participants, parents. The educational level was a decent split with 27% in advanced degrees and 22% in just some college and, college graduates, and then 20% high school graduates. And then our race for 50% white, as we did have 2 focus groups that were for Caucasian white parents. 30% were African American parents in the single focus group and 20% Hispanic in our other single focus group. Religion, 74% Christian and 24% stating no preference. And then the residents, 70% suburban, 26% city, and 100% Newcastle County, which is why this electronic survey, which we're trying to get disseminated statewide, will be valuable to see the attitudes and beliefs of the parents in the other counties. I don't know how to work this. That one. You can see the income spread as well. Again, with a decent mix in income levels, 33%, greater than 100,000, with down to 17% at under 25,000, and then insurance and healthcare, 78% private, at 22% Medicaid, and for those with sexually active teens, 24% yes and 28% unsure. The average age for the parents who participated in the focus group, the average age of their teen was around 14 years old of those who participated. Parents' birth control methods, only 7% actually have IUDs, and of the other, we're not sure of the LARC, how many had LARC use. 28% condoms, 22% sterilization. Did you want me to do more than demographics?
I can do this.
Okay.
Hello, everyone. My name is Anaya Coley. I am the study coordinator of the project. So some of the key themes that came from our parents' responses was the importance of sexually transmitted infections. That was one of the top ideas. Even though we were talking about long-acting reversible contraceptives, they were very concerned about sexually transmitted diseases and making sure we were counseling the teens on that also. Need for access to confidential birth control for teens of other parents, but not necessarily theirs. So in other words, it was good for other children that were not close to their parents, but it wasn't necessarily for their children. And the need for a clean, sterile environment with experienced personnel. So they just want to make sure that wherever they are getting these birth control methods, that the environment is sterile and clean, as most of us would probably want also. And there's a double standard between parents, teens, boys, and girls. And the next slide will actually show a quote from one of our parents. So, one of our parents said, "I have a son and a daughter. My views and concerns are very different because I have to worry about the possibility of her getting pregnant. But with him, I just have to show up to somebody's door and say, oh, sorry about that." So that just shows there is a double standard. You're more concerned about your daughter being pregnant because she's going to be the one to carry most of the burden. And this is another parental response, just talking about they're concerned about the safety and side effects of the birth control. You just got everything. Now I'm not privy to all these birth controls. I tried Depo, I blew up. But I'm like, if it ain't natural and what should be stopping your cycle when that's a God-given thing, and that should come naturally. They got pills, they got stuff to go on the arm, then you can see it, and I don't know enough about it that I would want my child to try this. So if the parents aren't into it, they're definitely not gonna want their child to use that method. So it just shows if it's safety side effects or if they're unfamiliar with it, they're not gonna want to use it. So when choosing a birth control method, which was very important in our discussion, the biggest idea was safety and side effects, just like the previous quote stated. They were concerned about future fertility. Will they be able to have grandchildren? Stopping cycles. Like she said, if it's not natural, she doesn't want to do it. And weight gain. And we all heard about the weight gain that comes from birth control. Just some of the advantages and disadvantages of LARC. Effective, that's an advantage. Ease of use and no worry. So the ease of use is it's not something you have to take every day or you have to go back every 12 weeks. Just some of the disadvantages, the parents are very concerned about STI prevention. Risky behavior, they felt like their children would be more prone to be more engaged in risky behavior, not protecting themselves for STIs or using other methods. Side effects that change the body because they are hormonal and hormonal body changes. So those kind of fall in the same line. Another response from a parent is, I do not want to make a statement. I got nothing against you that you're facilitating this session, so I'm always suspicious at nature. So these questions that if Nemours is sponsoring, it gives me the impression that Nemours is trying to target the Hispanic community for LARC. Then what's the underlying agenda there? Is it that we're overpopulating and there's too many kids coming out of our community, so let's stop your population, so let's give them LARC? Seriously, I get very suspicious at first. I have read a lot of stories, and it took all the way to our last focus group for a parent to actually come out and say this. They were concerned that we were actually trying to stop, population, but that wasn't the case. And in conclusion, mostly the knowledge from parents, they're not familiar with all birth control methods. The attitudes, they're very concerned with newer or unfamiliar methods, so a lot of them feel as though there needs to be more research done. STD, HIV prevention, they want to make sure that providers and counselors are educating their kids on the methods to prevent them from STDs and HIV. And parents want communication and involvement. Even though in the state of Delaware, children are able to consent to their own health care at the age of 13, parents still want to be involved. And just the beliefs. Most parents believe that confidential services were for kids that are out of touch with their parents. So like I said before, for kids that are not their kids. And just for future direction, we want to identify solutions to major barriers of LARC use, advocate for funding programs that enable adolescents to safely and easily access LARC, and ensure enough evidence-based research that STI rates are not increasing with the use of LARC. And this is our team again. Any questions?
Thanks for this great work. It's really fascinating to see that the parents in your focus groups have brought up things that have been studied, and it's clearly not getting out there to to the general public. So I think one of the important things that it brings up is how do we then translate the research that's already been done in ways that are acceptable to parents. My question is, so the parents clearly had the view that that confidential services, that's for other people's kids, not for mine. So I think one of the interesting questions that raises is, do the children of these parents feel that they are able to be as open with their parents as the parents seem to think that their children are? So I'm wondering if there are any plans to do studies with sort of teen parent dyads to get the perspective of both sides.
That was an idea that did come up, not right now, because we do want to understand what their goal is, because the parents are that first line that are going to be able to get to the teens. So if we can find out the relationship between them, then for future research, possibly we could do that.
Thanks.
I also want to add that from doing individual counseling at ARC's clinics, I do hear a significant number of teenagers say, my mom has said to me, come to me when you start having sex, and I'll take you to the doctor and get you on birth control, but the teens still feel uncomfortable.
I have a question for you. Hi. Just back to your structure of your research. Do you remember what your interviews involved with your stakeholders, like the kind of questions you asked and how you gathered that information?
They were individual one-on-one interviews, and we asked questions about their current practices, whether they were offering LARCs, who was inserting LARCs, what counseling were the patients getting around LARCs, what barriers were they encountering in terms of clinic flow and creating, access that was amenable to their patients. So it was those kinds of questions.
In this day and age, I know the concept may be obsolete, but was there any discussion on abstinence within the parents?
We did, in our focus group, ask parents questions about what they thought was the best way to prevent teen pregnancy, where they got their information about their bodies and about birth control, where they want their children to get the information. Abstinence did come up, but maybe not as strongly as some of us might hope. So parents recognize that abstinence is the best way to prevent pregnancy and sexually transmitted infections. And, you know, I remember in one group, we did have one mother, and she said, look, you know, I was abstinent until I was married, and I expect my daughter to do the very same thing. But there were a significant number of parents who said, yes, I recognize that that's the best way to prevent STIs and pregnancy, but I also recognize that that's probably unrealistic. Go ahead.
I just wanted to also let you know that on the electronic survey, in the questions, there's always, that are multiple choice, there are places where parents can answer opinions like that they don't feel that a teenager should be sexually active while they're a teen, or that it's not appropriate for teens to be having sex at this age. You know, there are always those kinds of answers available to them in the electronic survey. And also, when they are asked to give their opinions about what kind of birth control would be the best for teens, they can select abstinence as one of their answers as well. So it'll be interesting to see how those results come back as well.
Thank you so much.
So I'm very excited to introduce this final group of our panel. They are my colleagues from Christiana Care, and Dr. O'Donnell is actually a longstanding colleague and friend, so it's always especially wonderful to see the great work that people are doing.
All right, everyone. My name is Dr. Lindsay O'Donnell, and we are here today to talk about the evaluation of a homebound patient cohort for knowledge and interest in palliative care and reported well-being. My current role at Christiana Care is the medical director of our community-based palliative care program, but I have a wonderful team. Our community investigator, who couldn't be here today, is Naomi Stump of Christiana Care's Visiting Nurse Association. The research assistant of the project is Leslie Stolniker, MPH, and we also have the assistance of our hospice and palliative medicine fellow, Dr. Amanda Cooper, who's behind me. And we all work for Christiana Care. I did just want to take a minute to thank Excel for the funding and support and the ACE Award. Just a wonderful way to learn about and become engaged in community research. So I like to start off with defining palliative care because a lot of individuals don't know what it means. It's something that's coming up a lot more in the media, in literature, but still, there are some misconceptions. So to start off with, palliative care is specialized medical care for people with serious illness. It focuses on providing patients with relief from the symptoms, pain, and stress of a serious illness, no matter what the diagnosis. The goal is to improve quality of life for the patient and their family. And it's provided by a team of providers who work together, not to take the place of somebody's existing providers, but to be an extra layer of support. And it's appropriate at any age and any stage of a serious illness, and it can be provided along with curative treatment. It really works to treat the body through symptom management, the mind through psychosocial support, and the spirit through spiritual support. And palliative care, as mentioned, is provided along with curative therapy. When somebody's first diagnosed with a serious illness, something like COPD, CHF, end-stage renal disease, they may not have the same symptom burden that they'll have later in their illness. So maybe they'll need a little less palliative care. But as diseases go on, people face more symptoms, more complications, and palliative care becomes certainly much more beneficial and often prevalent to patients in those later stages. Many of you may be familiar with something called hospice. Hospice provides palliative care as well, but in the last 6 months of life, when 2 providers have certified that you're nearing the end of life. Palliative care can be delivered upstream to that. We're working on ways to do that. And it's been proven that it can very much improve quality of life, and in some studies, even length of life. So I'll take a minute to talk about the cost of care. We think about it in cost. Medical spending in the United States is very high. The costliest 5% of patients account for half of all healthcare spending, especially those with chronic conditions and functional limitations. But I want to take a minute to reframe that, to really speak on that the cost to the patient and family is probably the most important thing that we should be focusing on, the people out there in our communities. Nearly 70% of people die in the hospital, nursing home, or facility, but 70% of individuals identify that they'd rather die at home. Only a quarter do. More than 80% of patients with chronic diseases want to avoid hospitalization or intensive care when they're dying, but they're hospitalized and admitted to the ICU at high rates. And 70% of Americans actually die from chronic diseases. Only 20 to 30% of Americans report having an advance directive. That's a document that you fill out that basically talks about what your medical wishes are at the end of life, or if you were to get ill, who you'd want to make decisions for you, and what you would want those decisions to be. And when people do fill them out, they often don't share them with their physicians. So only a quarter of physicians even know that their patients have had an advance directive on file. In the United States, palliative care has been growing in prevalence, but estimates show that between 1 million and 1.8 million patients admitted to US hospitals each year could benefit from palliative care. Not that many are receiving it. You can't really see Delaware on this nice little slide, but it does have a B for access to palliative care from the Center for Advancement of Palliative Care. We actually are doing quite well. That came up from an F several years ago. But this only looks at access in hospitals. It doesn't look at access across the board. So, and you can see that, red is less access, and it kind of goes in areas with other health disparities. So we're working with our community partner, the Visiting Nurse Association of Christiana Care. They are a very important community partner. They've been providing care in Delaware since 1922 and care for so many of our patients, an average of 1,800 visits a day. The patients who are surveyed are patients in the VNA. They are homebound. That means it is an extraordinary effort for patients to leave their home and to go out into the community. They are at home.
So like Lindsay was saying, our population is homebound patients, and we really sought to understand some questions about the preference, readiness, and desire for palliative care or skilled nursing or hospice care among this population. And we wanted to understand what the prevalence of advanced care planning was in this community, and at what degree of functional status or level of quality of life that palliative care became very valuable to them. So from these questions, we hypothesized that as quality of life and functional status decline, we would expect that patients will be more inclined to choose options like palliative care services or hospice care services. And we expected also that among homebound patients, these are chronically ill patients or seriously ill patients, that they would have a greater percentage of advanced care directives completed compared to the general population. And that knowledge of palliative care in this homebound community is discordant with their interest and desire in palliative care. So we developed a 22-question survey to kind of get at some of these questions that we had, the bulk of which is something called the Missoula Vita's Quality of Life Index, which we'll discuss briefly, a couple of questions about their knowledge of palliative care and interest, advanced care planning, if they've had done any of that, and ranking their interest in different care programs based on where they are at this point in their care, and also an objective score about their functional status called the Karnofsky Performance Scale. And we worked with the Value Institute to determine that we needed about 350 surveys completed to power our study to see a difference between advanced care planning. So our community that we were working with were these homebound patients and all residents in Newcastle County, excluding Middletown and all areas south of the C&D Canal. And the surveys were obtained over the phone by research investigators and also by VNA nurses. So the Missoula Vita's Quality of Life Index is this was developed by a palliative care physician and really looks at 5 domains of quality of life and looks at 3 questions per domain. So for example, for well-being, it gets at an assessment of their well-being. My affairs are not in order. I'm worried that many things are unresolved, and it has a Likert scale in which they score this. It gets at their satisfaction, how satisfied they are with their well-being, and how important that particular domain is to them. Karnofsky Performance Status Scale is a 10-point scale that gets at functional status, but we can break it down a little bit simpler to kind of 3 buckets. If they score an 80 to 100%, these are people who are pretty functional, aren't needing a whole lot of extra care. 50 to 70% is where we expect our homebound patients to fall, who are unable to do kind of normal work, but they're able to live at home, but they need a lot of extra care. And 0 to 40%, you're kind of reaching that area of really serious illness and needing extra care, maybe hospice services.
So now for the results. It is important to note that although we have that goal of 350 patients, I'm only reporting on the first 50, but we are about halfway through the data collection. So we have about, I think, just over 150 done. So for the demographics for the first 50 patients, we had a split right down the middle of males and females, 25 of each. Race and ethnicity, we had about 2/3 were non-Hispanic white, and the other 1/3 were non-Hispanic black or African American. Because the population is homebound, the age breakdown is kind of what we would assume. Most of them are over the age of 56. We had a couple patients who are under the age of 55. I think the youngest patient in this group was like 28, and the oldest was like 95. So there's a very wide age range in this homebound population. So the first question of the Missoula VITAS Index is just how would you rate your overall quality of life from the best possible to the worst possible? And kind of going into this, me being the person who's actually doing this, I kind of expected them to rank their quality of life low because they're at home, they can't really do too much. But what I found was that 20 of them actually ranked their quality of life as good. And the next highest category of 13, they actually said their quality of life was the best possible. And knowing that these people are suffering from various serious illnesses, from chronic kidney disease to heart failure, I think that's a pretty interesting result to see. So the remaining 15 questions of the index can be scored based on their responses. The minimum score is a 0, the maximum is a 30. So a 17.6 was the mean for this group of 50 patients, just above the middle. But when I broke that down into more demographics, there was very little difference when I looked at it by race and by sex. But when I looked at it by age, I saw that the quality of life score increased as age increased, which I thought was really cool. So even though the number of oldest patients, we had like 2, I think, in the oldest age group, they actually had a higher mean score than those who were younger. And then what we would expect to see was that the global quality of life increases, the global score increases too. So when I looked at it by domain, I looked at the 5 domains separately, and the 2 lowest domains overall were function and well-being. I asked them questions about are they still able to do the things that they like to do. Obviously, a lot of them ranked that very low because they're not able to do much at all. And then the other lowest was the well-being, which Amanda went over earlier. So as far as functional status goes, we did have about 41 patients in that moderate range where they kind of need help, but they're still able to live on their own. We had 9 patients who were low. I think all of those were a Karnofsky score of 40, so they were disabled where they pretty much need help with everything. But when I kind of looked at functional status versus quality of life, I found that the people who had low functional status actually had a higher mean quality of life score than those who had moderate functional status, which I thought was interesting. And the one person who ranked her global quality of life as the lowest possible also had the lowest score and low functional status. So she was just kind of low all the way across the board, which is kind of what we would expect to see. So for the palliative care results, one of the questions on the survey, I simply asked them, have you heard of palliative care, or do you know what palliative care is? A lot of the times I have to repeat the term palliative care because they have absolutely no idea what I'm talking about. So not surprisingly, we had 24% of them say that they knew what palliative care was. But the next question, I kind of read them the definition of palliative care without actually identifying that that is what palliative care is. And after reading the definition, we had 82% of people saying that they would be interested in palliative care, which is great. So the next part, I kind of had them rank 3 different types of care services just based on simple interest. So kind of what we would expect to see with the functional status and quality of life score. Most of our patients were either the most interested or middle interested in skilled nursing and palliative care, which is good because palliative care can kind of be provided along with the primary care services. And the two people who were the most interested in hospice actually had the two lowest scores, and were both had low functional status, so those people might actually be appropriate for hospice, if not now, pretty soon. So now for the advanced care planning questions, we asked them 3 simple yes or no questions. The first question is just, have you talked to a doctor or a loved one about your wishes and what you would want if you can't make your own decisions? We had 70% of people say that they have done that. When I took it a step further and asked them if they had selected a power of attorney or a decision maker, we had a slightly higher number say yes at 76%. But when I took it to the next step and asked them if they had completed an advance directive or a living will or a 5 wishes or anything, that number went down to only 27 people saying that they had done that. And out of my own interest, I kind of took it a step further to see if it was actually accessible, kind of what they were talking about earlier, if it's actually in a record somewhere where a doctor or a nurse can find it. And only 8 of those 27 had an advance directive that was accessible in the main Christiana Care hospital record, which we're kind of going to work on improving, because if those people actually have them and we can't find it, it's not going to do a lot of good. So that's something that we're going to work on as well.
All right, so I think our time's up, so I'm going to be really fast with the last slide. This is hypothesis generating work. We need to take this data and we need to find out linkages and develop some more future questions about it relating to caregivers and advanced directives. But the last 2 take-home points I wanted everybody to know is that, this is something any of us work in, house calls, geriatrics, palliative care, a lot of other fields know. Quality of life in patients can be excellent despite physical and functional impairment. It really, truly can, and our job is to keep it there. You can provide primary palliative care, that's the palliative care we can all do, and specialty palliative care. Both of them together are essential to help our patients have the best possible quality of life and to honor their wishes at the end of life. Sorry for going a little long.
Thank you.
Teachers' pets.
When you looked at all the data, is it possible to sort of tease out the psychosocial wellness from the physiological wellness? Because I imagine family support, loved ones visits, things like that would be important for the homebound.
Some of the Missoula Vitas quality of life kind of looks at those categories, and we will be able to, once we get our full number of responses, hopefully bracket into those areas that really look for how secure patients feel. We have basic demographic information, but we don't have necessarily in this study specific questions about exactly what you're relating to, but I think by proxy we can really relate it to the Missoula Vitas quality of life. Thanks.
Thank you for your data. This is secular research. It would seem very relevant to me that we look at people's religious, spiritual beliefs, especially at this time in life, in terms of their willingness and acceptance regarding palliative care.
I agree wholeheartedly. I think that spirituality is a very important part of palliative care. As a matter of fact, for a palliative care team, it's ideal to have a chaplain on board. And if we don't have access to that, linking people to spiritual support out in their own communities. So I think that is a future step, is starting to, look at different faith-based communities. As you can see, some of that may be captured in some of these domains of quality of life, specifically transcendent, which interestingly, Leslie didn't mention, but of all the patients ranking their quality of life, that was the highest. They said they had the highest transcendent quality of life. And if anyone's interested, you can certainly email me, and I'd be glad to send you the Vitas Quality of Life Index so you could look at the specific questions, or you can grab us after. Leslie has, one here that you could actually look at the questions. Great. Thanks, everybody.
Well, thank you to every one of our morning presenters and keynotes. As the captain on the airline says, we're going to make up time in the air. So we're going to be back here right on time, sharp at 11 o'clock. And so please enjoy the poster sessions, get some coffee. We'll see you back here in 25 minutes. Thanks very much.